Hi, and welcome to my channel where I like to talk about medications and other health-related topics. Today I'll be talking about lipid screenings and the Prevent Risk Calculator. More than one quarter of US adults have a low-density lipoprotein cholesterol above 130 milligrams per deciliter. And this matters because the data shows that apolipoprotein B containing lipoprotein particles contribute to ASCVD. There is a lack of clinical trials showing harm or benefit in young adults for lipid screening, but because we are aware of the established relationship between ApoB containing lipoproteins and ASCVD, the 2026 ACC/AHA Multi-Society Guideline recommends that adults be screened at 19 years old and then every 5 years. About 1 in 6 or 1 in 5 adolescents have abnormal lipid levels, with 5% having an LDL greater than or equal to 130, and 1 out of every 250 US children have heterozygous familial hypercholesterolemia. Rates for lipid screening in children in the US is low, between 10 and 20%. Family history alone should not be used to identify childhood lipid disorders because up to half of those children identified with high LDL do not have a reported family history of hypercholesterolemia or premature ASCVD. The 2026 guidelines recommend universal lipid screening for children between 9 and 11 years of age who have not previously been screened to identify familial hypercholesterolemia and other lipid disorders. For those children with first or second degree relatives with premature ASCVD, FH, or severe hypercholesterolemia, it's reasonable to request a cascade lipid screening beginning at 2 years of age. In my last video, I briefly touched on the standard lipid profile, which directly measures total cholesterol, HDL, and triglycerides, in contrast to LDL and non-HDL, which are calculated. In both adults and children, a standard lipid panel is recommended to record baseline lipid levels, estimate ASCVD risk, and help guide therapy. The test can be done in a non-fasting state based on data that shows LDL cholesterol levels in persons with normal triglycerides usually differs minimally with normal food intake, and studies have noted similar prognostic value of fasting and non-fasting LDL and non-HDL cholesterol levels for predicting long-term ASCVD events. However, if there is a family history of dyslipidemia or premature ASCVD or a suspected triglyceride metabolism disorder, or when non-fasting triglyceride levels are 400 milligrams per deciliter or higher, a fasting lipid panel should be utilized to provide a more accurate LDL level. When I graduated, which was a while ago, the Friedewald equation was still the standard to calculate LDL levels, but it's no longer the preferred method because it tends to underestimate LDL when LDL is low, especially below 70, or when triglycerides are elevated, and when the test is performed in a non-fasting state as well. The Martin-Hopkins or Sampson-NIH equations are now the preferred methods to estimate LDL cholesterol. Non-HDL, which is the cholesterol carried inside all atherogenic ApoB containing particles, is a better predictor of ASCVD risk than LDL cholesterol, which helps explain why there is strong support for its routine reporting in a standard lipid panel. When should we measure ApoB or Lp(a)? ApoB directly measures atherogenic particles because each LDL, VLDL, and Lp(a) particle contains one ApoB molecule. In certain patient populations, such as those with CKM syndrome, diabetes, ASCVD, or hypertriglyceridemia, measuring ApoB may assess atherogenic particle burden more accurately than LDL cholesterol because patients with these conditions can have LDL at goal while ApoB remains elevated, which can indicate a residual cardiovascular risk. This is why measurement of ApoB is considered reasonable in adults on lipid-lowering therapy to help guide decisions regarding non-statin therapies if LDL cholesterol or non-HDL cholesterol are a goal. Lp(a) concentrations is mostly determined by genetics, and ASCVD risk increases continuously with higher Lp(a) concentrations and is independent of LDL cholesterol and other risk factors. Lp(a) remains similar over time with lifestyle factors having little effect on their levels, which is why the guidelines recommend measuring it at least once in every adult to assess ASCVD risk. The American College of Cardiology defines an Lp(a) of 125 nanomoles per liter as high. corresponding to roughly the 80th percentile and a 40% relative increase in ASCVD risk versus a population median of 20 nanomoles per liter. As a side note, fasting is not required to test for Lp(a) levels. Patients with familial hypercholesterolemia, premature ASCVD, or high Lpa levels should be informed that it's recommended that their first-degree family members, such as parents, siblings, and children, have cascade testing to help identify family members at increased ASCVD risk. To wrap up today's video, let's look at the PREVENT equations. PREVENT stands for Predicting Risk of Cardiovascular Disease Events. The equations estimate 10-year cardiovascular risk in adults ages 30 to 79 and 30-year risk in adults ages 30 to 59 without known cardiovascular disease. They provide separate estimates for total cardiovascular disease, ASCVD, and heart failure. Total cardiovascular disease includes both ASCVD and heart failure events. It was developed in 2023 by the American Heart Association and used data from over 6.5 million adults across the US and is free to use. The PREVENT calculator takes into account sex, age, systolic blood pressure, total cholesterol, HDL cholesterol, eGFR, BMI, diabetes history, current smoking status, statin use, and hypertension medication use. Risk estimates can be further personalized by providing urine albumin creatinine ratio, hemoglobin A1C, and the patient's zip code. For patients between the ages of 30 to 79 without ASCVD and an LDL cholesterol between 70 to 189, the 2026 dyslipidemia guideline now recommends using the outcome-specific PREVENT ASCVD equations to estimate ASCVD risk and help guide decisions about starting or intensifying lipid-lowering therapy. The results page displays the selected 10-year risk estimates and for those ages 30 to 59, the corresponding 30-year estimates. The calculator can also display results for ASCVD and heart failure, but PREVENT CVD is the default selection. The calculator also provides a PREVENT age and 30-year PREVENT CVD percentile. Both are based on the PREVENT CVD equations. The PREVENT age is an individual's predicted cardiovascular risk into an equivalent heart age. When PREVENT age exceeds chronological age, this suggests a higher than expected predicted cardiovascular risk relative to the peers of the same age. The 30-year percentile compares an individual's predicted long-term cardiovascular disease risk with people of the same age and sex in a nationally representative US population. For example, being at the 75th percentile means the predicted risk is higher than approximately 75 out of every 100 persons of the same age. It does not mean that the person has a 75% increased risk of developing cardiovascular disease. And that was your dose for medication education. I do hope you enjoyed today's video. If you did, go ahead and hit that subscribe button. It would make me happy, put a smile on my face. Thank you. Have a great day.